In this video lecture, we will be exploring applying the distress criterion for distinguishing between normal and abnormal behavior. So consider the case of Eleanor. If you characterized Eleanor's behavior as abnormal, you might have been doing so on the basis of things like the fact that she is 32 years old. So if you had seen this behavior in a 5-year-old, you might not have considered the behavior abnormal, but the fact that we are seeing this in an adult might have led you to characterize her behavior as abnormal. You might also have been thinking about the duration of this behavior. So she's characterizing herself as a lifelong picky eater. And you might also have been thinking about the ways that her behavior is affecting her experiences. So for example, if she can't access her preferred foods, she will wait to eat until she can access acceptable foods. So she might not be eating when she is hungry, or it might be affecting her ability to eat in particular kinds of social situations. So perhaps the ability to go out for lunch with colleagues, or to go to a social event like a wedding or a party or a celebration and be able to eat depending on the food that is available. In contrast, if you did not characterize Eleanor's behavior as abnormal, you might have been noticing that she does not appear to be experiencing any negative consequences of these behaviors. She's characterizing her weight as normal. She's saying that she does not experience hunger or other physical symptoms. She's reporting that she takes several daily multivitamins and supplements, so we're reassured that she may not be experiencing any nutritional deficits. And importantly, Eleanor is not bothered by her picky eating. She's not interested in changing her eating behaviors, and she doesn't feel that being a picky eater has led her to experience any negative consequences in her social or professional life. Eleanor's case identifies some of the challenges that we might experience using a distress approach to define abnormality. So if we are applying the distress criterion, we define abnormality as the presence of symptoms or experiences that are distressing, that are unpleasant or unwanted by the individual who experiences them. So, like our other approaches, the distress approach has some limitations. One is that some degree of distress may be normative or adaptive. So the fact that an individual is experiencing distress does not necessarily indicate that they are experiencing a behavior or experience that we would want to characterize as abnormal. This was a point of contention in the transition from the DSM-4 to the DSM-5 with the criteria applied to the diagnosis of major depressive disorder. So in the DSM-4, for a period of time after the death of a close loved one, an individual could not be diagnosed with major depressive disorder. And in the DSM-5, they suggested that this exclusion criterion be eliminated. So an individual who had recently experienced the death of a close loved one could be diagnosed with major depressive disorder, even if they had had a very recent loss. And many of the symptoms of major depressive disorder are very similar to what we see among individuals who are experiencing grief. So feelings of sadness or loss of interest, feelings of guilt, difficulty concentrating, trouble sleeping, all of these are normative and adaptive responses to grief and the loss of a close loved one. So there was a lot of debate over potentially changing these criteria because of the belief that this was pathologizing normative distress, the idea that not everything that is distressing needs to be defined as a mental illness. We can also see the opposite. So some individuals may not experience distress even when their behaviors are clearly abnormal according to other criteria that we have discussed. So some important words that we're going to be using over the course of the semester are ego-syntonic and ego-dystonic. Ego-syntonic, we can break this down. So ego is the self, and when we think about the syn in syntonic, you can think of words like synthesis or synchronous, things that go together. So ego-syntonic symptoms are symptoms that are perceived to be as core to the self or part of the self and are not experienced as distressing. So for example, Eleanor's picky eating was ego-syntonic. She sees herself as a picky eater and she is not bothered by her symptoms. In contrast, ego-dystonic symptoms are perceived to be as externally imposed or separate from the self and are distressing. So again, we can break this down. Ego is the self, and with dystonic, we can think of things that are discrepant or discordant. They are different. So ego-dystonic symptoms are seen as being separate from the self and are bothersome. And these are important ways of characterizing symptoms and disorders. So for example, when we talk about obsessive-compulsive spectrum disorders, we have two disorders in the DSM that have very similar names. We have obsessive-compulsive disorder, which is characterized by repeated obsessive thoughts and compulsive behaviors. And we also have obsessive-compulsive personality disorder, which is characterized by pervasive rigidity and an inability to delegate tasks to others and very high perfectionistic standards. Obsessive-compulsive personality disorder tends to be ego-syntonic, so an individual characterizes their experience as part of themselves. They're often not distressed by these experiences and don't want to change those elements of their personality. Versus obsessive-compulsive disorder, the obsessions and compulsions tend to be very ego-dystonic. So people find these obsessions and compulsions to be distressing. They seem externally imposed, and people would like them to go away. In addition, behaviors that do not cause distress to the self may cause distress to others. So for example, with Eleanor, she is not experiencing distress from her eating behaviors, but it's possible that individuals close to her might have concerns about her eating behavior, or her patterns of eating might cause distress to others. So for example, if her picky eating limits the eating options or food available or social opportunities that individuals in her family are able to pursue. And finally, behaviors might be harmful even if they are not causing distress. So Eleanor is reporting that her weight is normal and suggesting that she's not experiencing any negative physical consequences from her eating behaviors, but we might be concerned about possible long-term nutritional deficits or physical problems that she might not be aware of. So Eleanor's case illustrates a disorder that was added in the DSM-5 called avoidant restrictive food intake disorder. In the DSM-5, it is classified along with the other feeding and eating disorders, but it also shares a lot of characteristics with obsessive-compulsive disorders. So ARFID is characterized by disturbances to feeding or eating. So it might be avoiding food, it might be limiting eating to specific food groups or specific kinds of food that leads to a failure to meet an individual's nutritional or caloric needs. So they're not getting all of the nutrients that they need, or they're not able to consume enough food that they are able to meet the energy requirements of their body. And avoidant restrictive food intake disorder tends to be fairly ego-syntonic. Many individuals find that their eating is not something that they're interested in changing, and they're very distressed by the idea of deliberately changing their eating behaviors. But it can be associated with a range of negative physical consequences and nutritional deficits, and often also causes distress in interpersonal relationships. So the picture that I'm showing here is from a show on the Learning Channel. This is a woman who's avoidant restrictive food intake disorder. She was limited to eating pretty much only French fries and other potato-based foods. So you could imagine it would be really difficult to meet your nutritional needs if your diet is that restricted. So for another discussion of some challenges related to this definition of abnormality, I encourage you to check out this article that asks the question, is distress a symptom of mental disorders? Is it a marker of impairment? Is it both, or is it neither?